that closure is really very well described. There's a wonderful staff paper that's been done here. And so I won't go through all of the details, but it's very clearly described and it's concisely described. So I will save you some time in terms of what we did and how we did it. Suffice it to say that, again, there's never been a more collaborative effort in my years of service than the Ag News closure. And that collaboration was very broad. It started with residents and their families, and that was always first and foremost in terms of who we knew we had to collaborate with. But among the 3 regional centers who had primary responsibility for closure, with the State Department of Developmental Services, the director of the Department of Developmental Services and the agency, wonderful collaboration throughout. With legislators and legislative staff, in the Ag News closure, we had monthly meetings put together by legislative staff, which were so very helpful. During the process of the closure of Ag News Developmental Center, we were developing public policy and developing models of service for the first time, talking about buying homes at the same time that we were in the process of closure. In terms of timing, and I understand the concerns that have been raised about the deadline and the time frame and the goals, and it is a very ambitious goal. We had so many of the pieces that weren't put together when we started the closure plan, and that really added significantly to the time frame. And again, as an advantage in the current closure efforts, we have done and we purchased 60 homes in the Bay Area. We purchased those homes in 2007, which was at the very height of the real estate market in San Francisco, in San Mateo, in Alameda County, and in the Silicon Valley. So we did manage that. We couldn't manage the fact that we ran into a recession and the bond market fell apart, and that did certainly add to our time and took time. And I understand the need for detail and planning, and assure you we will do our best together with the department to make sure that you are provided with that. But I wanted to provide just a little background. We were given a substantial amount of money to begin the process of planning for closure, a significant amount of money. We have at regional centers, we have never planned on opening homes immediately upon receiving that money. It would not be appropriate for us to not meet with families, to not do what we do collaboratively with families, to identify where those homes are going to be located. Many of these homes, and one of the things I'm very proud of in the closure at Ag News Developmental Center, so we were able to locate homes near family members.
You have 2 minutes, sir.
Close to family members. And so until we meet with our families, until we have the time to collaborate, it would be inappropriate for us to get out there and buy homes. But we've certainly put the structures in place to be able to get out there and do that. We've established numerous collaborative processes. Locally, we have had 8 meetings with our families, and we continue to meet with them on a monthly basis to help them deal with this. This is very, very, very difficult for families, as you well know, Senator. It's a process. It takes time for us, and we are making progress. We have established numerous monthly meetings. I won't go through the list with the time I have available, but a long list of regular meetings, monthly meetings, with the administration, with the regional project of the Bay Area, with our line staff. We've lowered caseload ratios at our regional center to 29-1 to provide intensive support to families and residents who are going through the transition process. So we have ongoing dialogue with all who are involved. We will have to expand that dialogue to deal with physical medical issues have got to be dealt with. It has to be a holistic response to all of the needs of the individuals.
I apologize, but you have 30 seconds, sir.
Okay. In closing, I just want to say that throughout the closure of Agnews Developmental Center. I usually had two partners with me here. Santi Rogers, former director of the Department of Developmental Services, was the director at San Andreas Regional Center, and Jim Shorter, who was the director at Golden Gate Regional Center. We never stopped throughout the process keeping our focus on the needs, the individual needs of the residents, and developing the services and supports, all of the services and supports that were going to be necessary. The timeline is ambitious. We, again, will do nothing until we will not place people from the developmental centers until such time as all resources are in place and available.
Thank you so much, Mr. Burton, and I appreciate you keeping the time frame and not at all trying to be pushy. Want to make sure that we have time for everyone. I know the panel will have some questions for you here after this panel concludes, so thank you so much, sir, and it's great to see you. Thank you very much. Would now like to be able to turn it back to Mr. Doyle, the Chief Deputy Director for the Department of Developmental Services, to be able to talk about what's worked and where we can improve. Mr. Doyle, you have 5 minutes, sir.
Thank you. So the closure of Agnews was the first closure that focused on community integration as the primary goal for the closure. Previous closures focused on consolidation with other developmental centers. Some of the as Mr. Burton described, some of the new things that were developed for Agnews included the medical model home, the family teaching homes, the development of the community state staff program, the special managed healthcare provisions to ensure that individuals were receiving services as they transitioned out in the community, the establishment of the Bay Area Quality Management System, and the outpatient clinic to bridge the gap to ensure that services would be provided to individuals as they transitioned out into the community. In contrast, the closure of Lanterman moved considerably faster given the economic crisis and the budget pressures at that time. The stakeholder process was conducted from the time closure was announced on January 10th, 2010, until a closure plan was submitted to the legislature on April 1st, 2010. Lanterman had a significant head start, though, an advantage because of the investment that was made during the closure of Agnews and the lessons learned there. The Lanterman closure, though, did differ from Agnews in the following ways. Because of the economic crisis, there was no bond-funded housing program that enabled one housing developer to provide a major component of the housing need that was well-designed and coordinated. Instead, regional centers received funding through the community placement plan process for the Lanterman closure, and it was supplemented by the Southern California Integrated Health and Living Project, where 9 regional centers joined to form a collaborative partnership for resource development. The coordination and collaboration among the department and the regional centers was more challenging because at Lanterman there were 10 regional centers involved in the closure, where with Agnews there were only 3. While both the developmental centers operated an outpatient clinic during the closure process to provide a bridge for medical, dental, and behavioral services until services were available in the community, not all services were provided at Lanterman based on the qualifications of existing staff. Most notably, Lanterman did not provide sedation or anesthesia dentistry. With Lanterman closure, the department began a standard approach of working closely with 3 advisory groups for resident transition, quality management, and staff support for advice and recommendations through the closure process. An unanticipated issue encountered in the closure of Lanterman was the low usage of the community state staff program, as I mentioned. As a result, we're doing more to as far as education and outreach and, for our staff, and looking at other ways to make that program more successful since it has been expanded statewide. One of the principal lessons learned from past closures is the need for ongoing communication and collaboration at the local levels. Each DC is in a different community with a very different approach to needs and the population served. And what we've found that what works at one developmental center does not always work well at another. and ensuring that there are forums for local stakeholders to weigh in with what is working and what is not working is key to a successful closure. Some of the examples of this are the resident transition advisory groups that ensure resident transitions are careful, thoughtful, and reflect each individual's needs. The close coordination with the regional centers, as Mr. Burton mentioned, regarding development, allowing for changes or updates in development plans to better meet the needs of individuals in transition. Ongoing communication between the department, regional centers, providers, and the developmental centers to ensure that questions are being answered and that potential barriers are being addressed.
You have 2 minutes, sir.
Family meetings, newsletters, department participation in regional center meetings, and vice versa. And then quality management advisory groups to review data collected on individuals who have moved from the developmental center and make recommendations to the department based on the findings reviewed. Thank you.
Thank you so much. We appreciate Mr. Doyle. We're now going to be moving on to Kobe Pizzotti. He is a consultant with the California Association of Psychiatric Technicians. He's going to be talking to us about what's worked in previous closures on through their lens, as well as where we can improve. Kobe, it's really good to see you, and thank you for taking the time, sir.
Thank you, Mr. Chair and Senators. I appreciate it. Again, my name is Kobe Pizzotti. I'm with the California Association of Psychiatric Technicians. We represent roughly 1,700 licensed and regulated psychiatric technicians caring for the developmentally disabled in state-run developmental centers. Many of our members have been working with individuals with developmental disabilities their entire careers, and that is somewhere to the extent of some people have worked for 35 years with these people. Over the past 3 decades, we have seen several developmental centers close. Some of the closures have been better than others. The most recent closures were Agnews and Lanterman developmental centers. These 2 closures were vastly different in their outcomes, and we believe there are 2 primary reasons why. First, with the Agnews closure, the department provided employee groups with more information and was more communicative in the process. There was more information provided to CAPT, and more of the concerns were addressed and incorporated into the closure plans. This led to a more involved participation level from community providers in the Community State Staffing Program, a program which community providers contract with the state for state staff to work in community facilities receiving people transitioning from the developmental centers. However, this program was subsidized by the state for 2 years, which made the contracts attractive to the community providers. CAPT lobbied for this subsidization, as we knew providers needed the expertise of our professionals to help with the transition of a population of people that does not react well to change. Since the Department of Developmental Services did provide adequate communication, it allowed CAPT to signal the potential pitfalls of the program that were eventually mitigated by allowing many of the individuals that did not transition successfully to have a safety net facility in Sonoma Developmental Center. In contrast, the Lanterman Developmental Center closure was done with very little collaboration from the department. CAPT was adequately noticed on the process and was given opportunity to speak, meet, and discuss, but rarely were our concerns taken into consideration. Furthermore, Lanterman was the first facility to close where nearly all the clients were placed into the community with no safety net in place.
We have 2 minutes.
Additionally, there was virtually no community state staffing program established with this closure. Many of the Lanterman families that were once in favor of the closure now call for a moratorium on the additional closure of developmental centers until the promises made during the closure process are upheld. The Lanterman closure seemed hastily done with little input from CAPT or other unions taken into consideration. Very little investment into the community was done prior to the closure, and while all of the clients have transitioned into the community, many individuals would benefit from having a developmental center with a no eviction policy to which they could return. Psych techs do help with the transition of a consumer into the community. The level of care always note the daily routines, special needs, and specific information on what a client responds to well or dislikes, and ensures that the environment is the least restrictive. Many individuals thrive in certain open environments, while others need structured routines that do not vary. In many circumstances, even the slightest variance can cause a client to have a poor reaction. It is the responsibility of the level of care staff to ensure that this is noted in the transition plan. From time to time, level of care staff will travel with the clients to the new facilities to ensure smooth transitions and help establish living conditions and routines that closely match what the individual has become accustomed to. When learning lessons from previous closures, we must first acknowledge that no closure has been perfect. However, with that said, we should realize that one constant problem in any of the closures is the level of investment into the community resources prior to the closure of the facility. Not one of the closures had enough financial resources designated for the community.
You have 30 seconds.
However, the difference is that only Landerman closed without a safety net developmental center for those that did not transition well. This requires a different level of investment into the community to ensure that the proper resources are in place prior to an individual transitioning. What we have heard from the Landerman families is that their loved ones have suffered because of poor planning and investment. Hence, they have called for a moratorium on the closures. I just want to speak briefly about the community state staffing program. Currently, the community state staffing program is a standalone program. And when it is a standalone program, that requires that there be contracts in place in order for state staff to go to these facilities. There is no incentive for a group home provider or any day program to contract with the state for state staff when there's no subsidization of the rate in which they're going to pay for those state staff. A psych tech that makes $25 an hour versus a community provider is paying their staff $12 an hour, there's just no way that that can happen. And furthermore, there's no incentive for state staff to go into that community state staffing program because you don't know if you're going to have a contract for a month, 6 months, a year. And so there's really no incentives. We've offered a suggestion of an incentive to double service credits for people that go into state staffing, to go into the state staffing plan and to stay on at the facility for a recruitment or for a retention bonus to stay on until the end of closure. So you do not lose your staff and have them transfer into other permanent full-time jobs. So I'm just going to close with that.
No, I appreciate that. And again, not trying to be pushy, just wanted to make sure that we all get a chance. I appreciate your patience with me as well. So thank you very much. And for the last recommendation as well. It's good to see you. We're now going to move on to Dr. French. She's a staff physician at Sonoma Developmental Center. She's going to talk about the challenges of getting continuity of care in services after the closures. Dr. French, you have 5 minutes, and it's good to see you.
Thank you. So just for a little background, I'm a family doctor. My first 7 years I spent working in FQHC clinics. I've also been a solo private practice physician right here in Sacramento, and then I've been at SDC now for 9 years. It's also important for you guys to know that I have a brother with Down syndrome who lives in supported living right here in Sacramento, and I see very many sides to this complex problem that we've set out to work on today. So things that I see as difficult to replicate in the community. We've got 24/7 nursing and physician access. That's impossible to replicate. We also have immediate access to primary care and specialty care and sedated dentistry. Also very difficult to replicate. We also have caretakers who are licensed psych techs, which are invaluable. They have training that nobody in the community seems to have, and I realize that my brother is with untrained people completely in supported living, but it's really critical to have people with this level of expertise. And I actually think that it's a good plug for us to support this as a career, and to do that you have to have a living wage. The other thing that's very difficult to replicate what we do at the DCs is we have team-based management that includes a physician, a psychologist, a psychiatrist, and a social worker, as well as level of care staff sitting around a table talking about how are we going to help this patient with their complex psychological needs, their psych med needs, and their medical needs. That is impossible to replicate in the community at the level that we're doing. And I feel like it's the secret of our success. It's why people do better, get on less meds, and come up, we actually have the ability to come up with the behavior plans that work. And then, of course, we've already alluded to the continuity of care. Barriers that I see in the community as it stands right now, I just want to point out that aside from the developmental centers and all of the intellectually disabled people, we have a broken healthcare system in general. So these people are coming out into that broken system. So having access to primary care that is able to take enough time to work with our complex population, typical appointment lengths at a FQHC clinic are 15 to 20 minutes. Think of our patients as requiring translators. They require extra time. Try to imagine a physician trying to obtain the history from an unfamiliar staff, a nonverbal patient who takes some time to trust their new doctor. They might come in with a list that needs a psych med change, a wheelchair repair, their shoes to be modified. Try to imagine that at Kaiser. You know, I want you to have a real life understanding of what it takes to actually try and help these patients in the real world. The next thing that's a barrier is access to physicians with expertise in caring for patients with intellectual disabilities, along with the complex medical and psych issues. I consider the medicine I've been practicing for the past 9 years at SDC to have been the equivalent of a very specialized training in intellectual disabilities, epilepsy, and psychiatry. Very few primary cares in the community have any of this training. This lack of expertise will likely require a higher need and use of specialty care, and also a lot of destabilizing of patients.
You have 2 minutes, doctor.
Okay. Right now, I know that, from my brother, I know that his roommate can't get a psych appointment in less than 2 months. And he's not seeing a physician, he's seeing a nurse practitioner. So, like I'm saying, the healthcare system's broken. We don't have enough of what we need already. And trying to make sure that DDS and the regional centers can augment those services so that our clients have what they need is critical. Access to sedated medical exam and procedures, both with oral sedation and IV general anesthesia. It's one thing we're talking about with IV dentistry, but it's a whole other thing where people need a little bit of Valium or Xanax to get through their dental appointment. You need good nursing oversight to make sure that patient doesn't crash before, during, and after. And that's the kind of thing that I'm concerned about in the community. Then the other thing is, right now, I know from when I sit in the IPPs and I hear about what's available for my clients, the waiting list for IV, general anesthesia, sedated dentistry is anywhere from, yesterday I got quoted 13 months, but I've heard more like 24 months at UCSF and UOP. So that means that a patient can't get their annual dental cleaning. That's a big deal. That's a very big deal for a population that cannot adequately brush their teeth.
You have 30 seconds, doctor.
So the one big thing is access to medical records. We don't have an electronic medical record at our DC systems, and I really want to know what the state's plan is to ensure that physicians in the community have information that they need in a timely manner. How will they know who to call when the DC is closed to get the records that they need? So I have some ideas on this if you want to talk to me later about how to provide that. Access to crisis units, but I know that you'll speak to that more later. And I really do support the FQHC model. I'm a little bit concerned about when you keep talking about until the services are available in the community. I did read the background report, and it says that the clinics are supplied until the land is sold. And I'm really concerned about what happens once the land is sold. And I want to thank you for keep asking the very hard and important questions about details, because I do feel like this 2018 deadline is really ridiculous. I have a patient whose placement has been delayed for almost a year. They've had the house and the staff, but they aren't licensed. So again, you said it's individual, but I think that the 2018 deadline is actually leading to worsening of our staffing problems.
Thank you so much, Ms. French. I greatly appreciate it. Thank you. Well, so we're going to have everybody just hold here for a second. Dr. French is going to have you hold to see if there's any questions from the committee here to be able to ask any of you.